Hi, my name is Alan Prost and I'm your instructor for RESP 220, and today we're going to talk about Module 7, the physiological effects of mechanical ventilation. Our source for information on this is Egan's Fundamentals of Respiratory Care. Chapter 43 is the chapter you want to read for our references for this section. So what I'm going to do is I'm going to review the PowerPoint presentations with you and highlight what I think are some of the key points you want to remember from these slides. All right, so let's get started. So we've got our PowerPoint here. I'm just going to color along with me, and we're talking about Module 7, Physiological Effects of Mechanical Ventilation on the respiratory system specifically. Okay, now we've already talked about in class how our basic settings on the mechanical ventilator, we usually have a little bit higher respiratory rate and a little bit higher tidal volumes than you normally physiologically have, and that's because we've got increased amounts of dead space ventilation. All right, and that's because the ventilation goes primarily to the most compliant regions of the lungs and areas of poor perfusion. So that's just an example of one of the major physiological effects of mechanical ventilation, and we're going to review that in many of the others. Okay, so what are we going to be talking about? Barotrauma, Volutrauma, Atelectrauma, Biotrauma, and oxygen toxicity. Now, I know we've been referring to those in the class, but we're just going to give you a little bit more detail on those. All right. Sometimes you'll hear me refer to a ventilator-associated lung injury, and so that's what wraps up and talks about all this damage due to positive pressure ventilation on the lungs. So, barotrauma. When we have a lot of pressure inside the lungs, we can actually rupture the alveoli themselves and release gas right into the interstitial space. And that's what we're talking about here, that interstitial emphysema. Sometimes you can actually get some of it leaking out and you can feel it around either the neck or areas outside the lung area themselves. But often it's right in here inside the lung that it creates the biggest problems for us. And you can see that on chest x-rays. And this means that we've got areas now that the air is not moving around and it can actually decrease the compliance of the lungs and limit gas exchange. So that's really problematic. Of course, a major problem would be a pneumothorax, where we're going to get air collecting between the lung and in that pleural space in here. We're going to have to put chest tubes in place here to keep that lung units distended. All right, this is actually in some ways easier to manage than interstitial emphysema. A pneumopericardium, where we get air collecting around the heart like this, can be very problematic and can be life-threatening very quickly, because that increased pressure around the heart can actually severely decrease cardiac output. So we have to be knowledgeable and diligent about these, but of course, how do we prevent them? That's the big question, and we'll talk about that very soon, in that we limit the plateau pressures. All right? So volutrauma. Now, the concept of this is where we put in a set volume. And in this case, I'm going to say, well, say we're putting in a regular tidal volume to a patient of 500 mils. In a normal, healthy person, this would be equally distributed to all the lung units. So here we are at our basic PEEP, and as the flow goes in, I'm going to get some volume in here and some volume equally distributed between those. But now if I put in that same tidal volume, 500 mils, into a lung unit that's got variable compliance, less of that volume is going to go into these areas of poor compliance, which is often the diseased, so we've got low compliance, and these with normal compliance are going to be over distended. So this would be the concept of volutrauma, this over distension of healthy units. And how do we prevent that? Often by, again, limiting the pressures in the lungs. So instead of putting in a set volume each time, we can limit the damage of volumes by just using a pressure target instead, and thus why we often use pressure control ventilation. All right. Atelectrauma is where we actually get sections that are collapsing and sticking together. All right. And I know I've mentioned this in class a couple of times. You've heard me doing my clapping of my hands, talking about the dangers of atelectrauma. All right. Here, because of the low surface tension, what happens is the alveoli will actually collapse and stick together. Now the danger, of course, is when this pops open. The shearing forces here can be huge and actually can cause rips and tears in the alveoli themselves and can cause capillary injury. All right? So that's what we're causing. And this is that shear stress is caused when we allow the alveoli to pop in and open. Now, if we've got areas that are just just collapsed all the time, of course, we're not going to get good gas exchange there, and that's going to affect our gas distribution and our blood gases. All right. Biotrauma, this can occur when we get the body's actually reacting and damaging the lungs themselves. So we get these inflammatory mediators, and this can often be associated with ARDS, for example. And this can actually damage the lung tissues themselves, causing that decrease in compliance. And of course, we're going to have increased oxygen demands, things like that going on. All right. A primary mechanism for this is if you had somebody who aspirated gastric contents, and they get this huge inflammatory response in the lungs, for example. So how do we manage this with a ventilator? Well, we've got to decrease the pressures, try to maximize oxygenation, and keep the patient alive long enough so that their own body can start to heal itself. All right. So what are some of the physiological effects of positive pressure ventilation? And of course, we talked about those shearing and ripping forces, and that's what you can see occurring right here in this diagram here. And we know from controlled experiments, so what this photograph here is showing us, that over distension and repeated tearing of the alveoli like this causes this change in our lung structures to this darkened and damaged areas of lungs like you're seeing in here. And that's due to over distension and this tissue shearing forces that we're seeing. All right. So what are some of the other effects that we should be aware of as respiratory therapists? Well, if we cause a lot of air to be going into the chest, sometimes with asthma patients or COPD patients, we can actually get air trapping. And this is where we haven't allowed enough time for exhalation. All right. So often, if we increase the TE, we can limit these effects. All right, letting more time for exhalation. The reality is that air trapping and auto PEEP can often be beneficial to our patients because it actually increases mean airway pressures. All right. So in severe cases, we sometimes manipulate air trapping to the benefit of the patient to increase mean airway pressures. All right. It also causes a mechanical bronchodilation, allowing airflow into some of those distal units that would normally be collapsed. And of course, we're going to increase functional residual capacity. So like a lot of things we do with a mechanical ventilator, there's positive and negative effects to things like air trapping and auto PEEP. All right. The mechanical bronchodilation, when we keep PEEP in the airways in the lungs and we inflate them, this causes the airways to be open larger, so it actually decreases airway resistance. Increased functional residual capacity means I've got less area for a pneumothorax or air atelectasis to occur. All right. Well, we know that when we put people on a positive pressure ventilator, we're doing things very differently than when they're spontaneously breathing. And that can change where that ventilation is going to go and its effects and how well it's going to participate in gas exchange. All right. So perfusion goes to the gravity dependent areas, but often when we put people on a positive pressure ventilator, the ventilation does not go in the same place. So we get this increased dead space ventilation. All right. We get an increase in the VDVT. All right. Okay, well, that's fine. And we can compensate for this by increasing the patient's overall minute ventilation. All right. And we see that in our basic ventilator settings. A normal person will have a minute ventilation of about 5 liters per minute. On a mechanical ventilator, it also has to be 6.5 to maybe even 7 liters per minute. All right. And that's because of this unequal or unusual distribution of a positive pressure breath going to the, say, more to the apices or to that zone 1 than to the areas that have good perfusion. All right. So we get both an increase in dead space ventilation and an increase in shunting because some of those areas where there is good blood flow, there's not enough ventilation, so that blood goes through without participating in gas exchange. So that's a shunt. All right. So here's another example of how that happens in our spontaneously breathing patient. Even though they're laying on their back, most of the ventilation and perfusion is matched quite well because the diaphragm moves down, and of course the blood flow is going to be mostly in this region here where most of the ventilation occurring. So you're going to have a fairly normal gas exchange and dead space. When we push the air in, instead of it going to those lower regions here, its focus is to these upper regions because they have higher compliance. It's just easier. These ones are engorged, they've got blood circulating all around them. And so the ventilation tends to go to these upper apices, but with very poor perfusion. So the result of that, we get VQ mismatching. All right, so the infamous VQ mismatch. That means we need more minute ventilation to get the same PaCO2. Okay, so physiological effects, positive pressure ventilation. You're hearing me say that a lot. Pulmonary vascular resistance. This is tough to get your head around because in some instances it's decreased and in some instances it's increased. All right, so we can get a decrease in pulmonary vascular resistance because we actually have higher PaO2s and lower CO2, and that will improve pulmonary perfusion. We may get an increase in pulmonary vascular resistance when we have actual compression of the alveolar capillary membrane and the capillary around the alveoli with overdistension of the alveoli. So the alveoli is pushing out here and it's increasing pulmonary vascular resistance, so very little blood gets through here. Now this is important clinically because when this starts to occur, increasing PEEP and pressure in the lungs is going to be detrimental. All right, so instead of actually improving oxygenation or improving blood gases, you'll have the opposite effect because there's just simply no perfusion occurring in these areas. And you see that sometimes in neonatal patients when you actually have to back off on the ventilator pressures. Okay, how do we minimize these effects? This is the critical element for us as respiratory therapists. First thing we're going to do, we're not going to put in very big volumes. We're going to use low volume targets, 6 to 10 mils per kilogram, and we did that in our case study in class the other day. We're also may consider permissive hypercapnia. So instead of having that PaCO2 goal of 40, maybe we'll allow that to rise and just keep an eye on the pH. So we can have a patient whose CO2 is 80 or even 100, but as long as they're not too acidotic, we'd be okay with that. So by limiting the amount of minute ventilation, we can limit the amount of damage due to volume/barotrauma. All right, make sure the endotracheal tube placement is correct. We're going to do that all the time. Avoid these sigh breaths, those a little bit larger type breaths, and we do that with specific type modes like airway pressure release ventilation. Okay, and we can use PEEP appropriately, and that's a difficult thing to do. We're not sure what some of the PEEP levels we're supposed to be using, but we know that if we can prevent that atelectasis and that shearing, that might be a good thing for our patients. So we always have a little bit PEEP on board, and if they're really sick, we might go up to 8 or even 12 centimeters of PEEP, depending on their disease process. All right, we're going to monitor for auto PEEP so that we're aware of when we're potentially over-distending the alveoli. And we're going to minimize de-recruitment with our appropriate use of PEEP. You notice the word PEEP coming up here a lot. So we spend a lot of time thinking about what the appropriate PEEP level is, but it's very hard to do. And we're going to talk about other strategies next year with the ventilator and looking at our waveforms to optimize PEEP. All right, so the ventilator doesn't just affect the lungs. Now, as respiratory therapists, that's a big shock to us. Well, how else? What else is there? But in fact, there are significant cardiovascular effects. It does affect cerebral perfusion. There's all major systems such as the renal and liver system, even the gastrointestinal system. We have some psychological effects on our patient. Just being on a mechanical ventilator, I mean, let's face it, you're not on a mechanical ventilator unless you're in a life-threatening situation. We've got changes in metabolism, and of course, being on a mechanical ventilator can cause muscle atrophy. So let's take a quick look at some of these. Okay. Now, with a normal spontaneous breath, we create negative intrathoracic pressures. So when we do that, we actually increase venous return. So we take a Big breath are in, and when we breathe like that, we enhance venous return into the thoracic cavity, and that promotes filling of the right side of the heart. So the right ventricle receives a good filling and the preload's improved. So that can actually increase cardiac function when we spontaneously breathe. All right, but it's reversed when we have positive pressure breaths. So in a spontaneous breath, we enhance venous return, helping fill that right side of the heart and improving cardiac function on a spontaneous breath. Okay, but in a positive pressure breath, this is reversed and limited. All right, so when we force air into the lungs, we decrease right ventricular preload, the exact opposite, and this can actually decrease cardiac output. So it's a subtle but an important effect, and this can be very important for a patient who's already got limited circulating volumes and poor cardiac output. This effect on the thoracic system should not be minimized. An example of how I can get you to apply this thought process to this is if you put a pulse oximeter on your finger and you take some long, prolonged, deep inspirations through pursed lips. When you create a lot of negative intrathoracic pressure, you'll notice that your heart rate actually decreases. Most healthy people by about 10 or 15%. And that's an example of this thoracic pump in operation. Yeah, try that in the lab sometime. All right. So unlike before, with positive pressure ventilation, we're pushing and creating back pressure against that filling during inspiration. So inspiration now is a positive pressure element, forcing blood out of the upper thoracic cavity instead of drawing it into the blood, into there. So we limit the preload on the right side, and that decreases cardiac output. Here's another way to view this. All right, so you can see here we're enhanced venous return with spontaneous breathing. So we're improving that, all right, because we've got this negative intrathoracic pressure. So we enhance that venous return, enhancing right atrial and right ventricular output. Okay, with a positive pressure breath now, we actually push against these vessels, and that decreases our venous return. So we're actually pushing some of the blood out of the thoracic cavity, decreasing that, limiting right atrial preload, limiting right ventricular function. So that's a major effect on the cardiovascular system. All right, there's nothing we can do about that. All right, so whenever we have transmission positive pressure, usually with the PEEP and those larger mean airway pressures, we're going to decrease cardiac output. So the amount of PEEP and your positive pressure ventilation and your mean airway pressures are a major effect on cardiac output. Now, of course, if you've got a disease process like ARDS, where the lungs are very stiff, the amount of transmission of that pressure to the thoracic cavity is diminished. So if you have an emphysematous patient, for example, that's going to increase this effect. All right, that's our COPD patient. Pressure transmission is very effective, so these patients are going to have dramatically decreased cardiac output, where these ones, it'll be a less effect. Thoracic compliance also plays a part of this, because if you're pushing against a stiff abdomen, or you've got a stiff chest wall, the amount of pressure that's going to be built up in the thoracic cavity is greater. All right. So the effects of positive pressure ventilation on the cardiac system impedes cardiac output, decreases blood pressure. All right. So the patients that we're most worried about that, hemically unstable patients, MIs, for example, patients with low circulating volume. So if they've got shock, all right, if they're hypotensive, this is going to be a much more important effect. Okay. One of the other things that can happen is that we can have or cause a change in intracranial cerebral perfusion. Well, that seems like a hard thing to get your head around, all right? That changes in cerebral perfusion pressure. But we know there's two mechanisms at play here. One is that if we hyperventilate a patient and lower their CO2s, that decreases blood flow to the brain because this causes vasoconstriction. So that's a mechanical effect that causes that. The second one is when we have increased intrathoracic pressures, we decrease the blood returning from the brain, and that can reduce the overall pressure gradient, decreasing cerebral perfusion. Well, that's cool, but what does it mean for patients? Well, we're just going to limit both of these effects. We're going to limit hyperventilation, and we're going to limit the amount of pressure we can, if we can, in the thoracic cavity. Sometimes there's just nothing we can do about it. The patient will just have to survive. So, surprisingly enough, the renal system is also affected by positive pressure ventilation. Now, I don't want you to memorize all these different responses here, okay? I want you to be aware that if we have a patient who's hypoxemic, a patient with high CO2s, we're going to damage and cause decreased kidney function, all right? How do we limit this? By keeping the PaO2s in the normal range, keeping the CO2s in the normal range, and not allowing large pH imbalance, all right? So that's how we limit the physiological effects of positive pressure ventilation on our kidneys. I don't want you to try to remember all these ADH and ANPH releases. All right. How do we monitor kidney function? Ask the nurse, what's your kidney function? How much urine output are we having? Those kinds of factors can be important. All right. Just for an FYI, liver function can be impaired. We've got increased positive pressure in the thoracic cavity, and that's going to directly affect hepatic blood flow. So anything that impedes liver blood flow is going to decrease its effectiveness. All right. The gastrointestinal system is a kind of surprise to us. We know that for some strange reason that when we put patients on positive pressure ventilation, they tend to get more gastric bleeds, they get ulcers, there's a lot more requirement for antacids, and we also were concerned about that gastric reflux causing ventilator-associated pneumonias. All right, so how can we prevent these? Well, if we can, we try not to intubate the patients. We try not to give them ventilation for any longer than they need it. And sometimes using non-invasive can also be helpful. All right. When we put a patient on a positive pressure ventilation, we do that often because we're trying to decrease their workload. So we're trying to allow the body to heal itself. All right, we decrease O2 consumption, we decrease CO2 production, and this can be very important because a lot of, or there's many conditions that cause a hypermetabolism, and such as with major surgeries where the patient's need for oxygen and CO2 production are greatly increased. So in these situations, reducing the demands on the body can actually reduce how much oxygen we need to deliver to the patient. How do we combat these? Well, make sure they're they've got good nutrition, and we keep their gases in the normal range. When we keep a patient on a positive pressure ventilator for a long period of time, we're going to get muscle atrophy. This used to be a big concern for us, and we thought about this weaning process. But we know now that many patients can actually bounce back quite quickly, and we need to get them off the ventilator as quickly as possible. So some patients are going to require mechanical ventilation for an extended period of time, and we may have to have a kind of a weaning process to get them used to breathing on their own again. But for many of our patients, as soon as their disease process resolves, we can get them off the ventilator. So be aggressive in trying to get them off the ventilator. Being on a ventilator is psychologically stressful, not just for the family, but also for the patient. As you can imagine, they're relying on this machine to keep them alive. So it can be very difficult to sleep in this noisy environment with that tube in your throat and your chest being filled in by a mechanical device. We know that causes a lot of anxiety and frustration, that they become ventilator dependent. They become depressed often. And this you have to watch for, because when they start getting those kinds of symptoms, they believe they need the mechanical ventilator to survive. So when you're talking about, oh, we're going to get that tube out and we're going to extubate you today, that can actually increase them and their feelings of helplessness, their need to be suctioned. They're actually in fear of you taking the ventilator away. So how are you going to deal with that? You're going to be positive with your patient. You're going to be clear about what you're trying to do with them and why this is beneficial with them. You're going to make sure that you talk to them as a human being, even if they can't respond to you. All right, and when you're suctioning them, you're going to make a little bit of eye contact, and you're going to be talk them through it, even if they seem semi-conscious, because a lot of times they're hiding out inside the back of their head. They're not really unconscious. All right, so I've given you a quick review of the effects of positive pressure ventilation. The focus of this course clearly is the control interactions, understanding things like the I to E ratio and the timings in those basic modes, but you also need to have a little bit of a background on what the effects of positive pressure ventilation is. All right, so my name's Alan Prost. I hope you enjoyed the class, and I hope this video is somewhat useful for you. Thank you very much.